Well, good evening, Dr. Bello. Good evening, Dr. Bello. Good evening, Dr. Ronari. Hello. Hello.
Good evening, ma'am.
All right, dear. Good evening.
Good evening, Dr. Gina.
Oh, thank you for coming on board.
I'll make you the host now. I'll leave the meeting. Is that okay?
Yes, good evening.
I
Oh,
want to-
Dr. Bello, thank you so much
So the
for
exam
all
is
you
now
do for
live
us.
it's now live on YouTube. So what you do is now is that I'll make you the host, then I will lead the meeting so you can control the meeting.
Yes, make Ronari, make Dr. Ronari, Charles and me.
Yeah, it's equally he's a co-host. Dr. Charles is a co-host.
So you
be the
make
host.
me co-host.
Leave now.
Okay.
There's mosquito here. Oh. This one where they fly a mosquito or what?
Yeah. And Dr. CNN is not joined us yet. Please, so let's keep on sharing publicity. It's already time for the meeting, and it's just a few of us, just 4 of us.
Hello, Dr. Regina.
Yes, good evening.
Good evening, ma'am. Please, I'm trying to see how I can share, but I've not been able to successfully do that. I'm trying to share my screen. We have not.
Okay, to share.
Let me just work on it quickly.
Wow. So you've not been able to share your screen.
Yes, I'm working on that
Hello?
now. Let me see.
Okay. Please do.
Share screen. Why did they know they allow me share screen now?
Yes, we welcome everyone that has joined us. The meeting will soon start. Welcome, everyone. Please be patient with us. The meeting will soon start.
I go get 600. Oh, cash. How do you want the 5? Like, this means you the 5. So, we are balanced. You're a Christian. So for 5.
And be recognized, you will ask your questions. And then the presenter will answer your questions. So please, while waiting for him, while waiting for the presenter and trying to sort out some technical challenges, let us mute our speakers and then so that we can take off effectively. We appreciate everyone that has joined us. Yes, I can see Dr. Chinwe. You are welcome, ma.
Hey, what are the lights? Jessica, good light.
I don't even know the place. London, go and bring that part for me fast. Go and bring my wrapper inside the room fast.
It's not started.
Good evening.
It's not the one to start.
Okay, good evening, sir. Yes, sir.
Thank God. I did
No, it's not. I have not come back.
It's not started. Is it time for dinner? What are you guys eating? Indo, watch it. Sandwich.
Yes. Sardine sandwich. Fish.
Okay, please, while waiting for the presenter, can somebody take the opening prayers, please?
Can I take the opening prayer?
Amen.
Good evening, ma.
Okay,
Can I
I
take
want to remind us that the clinical meeting tonight is from the Pediatric Pharmacists of Nigeria. I want to believe that the majority of us here are on that Pediatric Pharmacist platform. You know that our association, our group rather, started last year. While waiting, I just want to remind us of who we are. We started last year as Pediatric Pharmacists of Nigeria. We are a subspecialty of the Clinical Pharmacists Association of Nigeria. This day is our first official outing, though we have been having some meetings, particularly the steering committee, but today is our first official outing. And like we have the presentation, I want to remind us that our focus as pediatric pharmacists is on the pediatrics. I hope you are hearing me. Oh, there's technical issues. The Pediatric Pharmacists of Nigeria, PEDPON, we have a vision. Our vision I hope I'm audible. Please, someone should let me know if you can hear me.
You are audible.
Oh, all right. Thank you very much. Okay, just to remind you, about our slogan. Our slogan is as a specialist group of CPAN, we advance specialized pharmaceutical care for children. Our mission is advancing best practices in the pediatrics pharmaceutical care through collaboration or specialist clinical pharmacists or aspiring specialists with advanced knowledge and expertise in a multidisciplinary healthcare system. In other words, we collaborate with other healthcare professionals. Our aim is to optimize healthcare in the pediatric population. Or not talking about pediatric population, that is from day 1 up to the age of 18 years. Our vision in this specialty is to be the leading pediatric pharmacist association in Africa. And we are projecting expertise in practice of specialized pharmaceutical care, as well as maintenance of wellness in children. That is what we are set to do in this pediatric pharmacies. And because we know that medication therapy in the pediatrics is not exactly the same as in the adults, there are certain principles guiding dosing and therapy in the pediatrics. And that is what we are set to do today, to enlighten ourselves, to remind ourselves, to educate ourselves about these principles. Or there's this belief, this erroneous belief that the pediatric is a kind of mini adult. But no, scientifically, we know that it does not go the same way. There are certain parameters that guide medication dosing in the pediatrics. That is what we are set here to remind ourselves. And our presenter for tonight is one that is well known to us all. He is known as Dr. CNN. His real name is Dr. Charles Wako. So he will be taking us today on the principles of Dr. Charles Wako has PharmD, as the Doctor of Pharmacy. He is a fellow of the West African Postgraduate College of Pharmacy. He is also a member of the Clinical Pharmacists Association. He is a member of the Paediatric Pharmacists Association, where he functions as a publicity secretary. Dr. Charles is the Deputy Director, Drug Information Service, Pediatric Pharmacy, and other inpatient services at the Federal University Teaching Hospital, Owerri, Imo State. I hope I'm still audible. There seems to be a lot of let us mute ourselves. I said, Dr. CNN, we all know him by his writing. He's a man of the pen. He writes about a lot of issues affecting pharmacy profession in Nigeria. So today he's focused on this topic and explaining to us what we need as a guide for pediatric medication. Once again, I want to appreciate everyone that has come up. Please, we are still waiting for the presenter. He seems to have some technical issues, but please bear with us. We pray that the technical issues will soon be overcome. Oh,
Dr. CNN has already joined the meeting.
He is here. Dr. CNN is here with us live. So you are welcome, doctor. And we have just introduced you and your topic. So, Dr. Ronari, I don't know if all is well. Can we start? Can the presenter take the floor down? Dr. Ronari, let us know our host.
Okay. Thank you, Dr. Regina, for starting up the clinical meeting. We are expecting Pharmacist Hafsat, our secretary, to project for us. I've sent her the work, so we're expecting her to project that now. Let me. She seems to be mute. Let me ask her to unmute and then project. Just let me get across to her now.
Okay, so please be patient with us. Dr. Hafsat is our secretary. I believe she will soon share the slides. Start sharing the slide. I said earlier, our presenter, our very popular Dr. CNN is here live. So we are now waiting for the slides. Dr. Hafsat has the slides and will soon project it.
Okay, please, we need feedback. I hope we can see the shared slides.
Oh, beautiful. I can see the slides are now ready for sharing. So at this juncture, I want to invite our presenter. Our presenter, Dr. CNN. Sir, you are welcome. I have already introduced you, so please, you have the floor. I want to remind us of our topic today. It is principles
I think we can go on now, ma.
All right. So the slides are there on the screen. We want to invite the presenter. Dr. TN, please, you have the floor. Principles of medication dosing in the pediatrics. Okay. I think the presenter is still having difficulties. Maybe I can just start with a presentation while waiting for him. Dr. CNN, are you with us? Dr. CNN. Dr. CNN, are you with us? Okay. I guess the time is going. Let me just read the objectives and then we will continue from there. It's still issues with network.
Ma, I think you can go on with reading the preliminaries for us. With the preliminaries, we can go ahead. Then when he is able to get his issues fixed, he can continue from that point.
Wow, computer.
Okay, I have between this which one comes first? R-A. The next one. The last one. Easy. X. Yes. Me. X.
Why is it box? Why is it box? Every other letter. What's the next? Next one. That one. Gather your pencils, gather your sharpener, your eraser. Do very well with your assignment.
Dr. CNN just put up a chat. He's having issues with his audio device. I don't know if there's anyone that could take up the presentation on his behalf. James, you have two devices logged on. I think you may have to log out one, or at least this distance is reasonably from the other one. It's echoing because you have two devices on. Hello, Dr. Regina, can you hear me?
Okay.
Dr. Regina, are you there?
Okay, that's a challenge. So
You have two devices logged in on this meeting. Could you log one out?
Presentation that at the end, I hope I'm audible. At the end of this presentation, we should understand.
You have two devices logged on. You have two of your devices in this room. Can you log one out? The reverberation is it's messing things up.
Okay, I'm just going to mute those who are not expected to speak at this point.
Can I go on? so much technical challenge.
Hello, Dr. Regina, please kindly unmute one of your devices. I'm trying to mute the second one. I think I mistakenly muted both of them. Kindly unmute one of your devices.
Oh yes, can I continue? Like our presenter cannot make it.
Kindly continue, ma'am.
In the simplest to first made a National Assembly complex, so that they recommended the policy or modified the way it's being implemented. Said Nigerians are now suffering because of lack of cash to meet the others stated that the president should
Okay, I hope I'm now audible. Please can you hear me now?
Ma, you are audible. Just go ahead.
Okay. I will start with, like I said, our presenters there seem to be a lot of technical challenges. So the outline for our presentation today is that at the end of this presentation, we are expected to understand some age-related changes in physiology, biochemistry, anatomy, pharmacokinetics, pharmacodynamics, pediatric. We shall be abreast with how these age-related changes are viewed in dosing in the pediatric. A lot of technical challenges. Okay, the main principles of pediatric drug dosing is that pediatrics is a branch. It's a branch dealing with prevention, that is talking about immunization. It deals with health promotion, including breastfeeding, treatment, early recognition and screening. It recognizes interdependence and factors in child's health. Recognizes the organic structures, abnormality, functional and substructural abnormality. It recognizes behavioral, social, economic, like poverty as the situation is now, where cash scarcity is seen to be ravaging the country. Recognizes the political, also the political atmosphere. It encompasses specialties like internal medicine, O and G, that's talking about obstetrics and gynecology, and then the neurology, psychology, psychiatry, nutritional, that's talking about enteric and enteral nutrition, and all others. And then the gestational age, and this includes premature, that's preterm of less than 37 weeks gestational age, postterm, that is more than 42 weeks gestational age, and then full term, about newborn, neonate of 0 to 28 years. That's classifying pediatrics now. It includes infants. Infants is from 1 month to 12 months. Talking about childhood, which can be classified into early childhood. Early childhood is from 1 year to 4 years. And then middle childhood, which is 5 years to 10 years. Adolescence is 11 years to 18 years. Now, pediatric pharmacy is a clinical pharmacy specialty. It, like I said earlier, it involves the use of drugs in ages ranging from day 1 to 18 years. And then the peculiar characteristics of pediatric in drug usage. No, like I said, certain parameters makes the use of medication in the pediatric to be unique and different from that of adults. They include varying pharmacokinetic processes, because these parameters function differently in the pediatrics. They include varying pharmacokinetic parameters like half-life, elimination constant, varying kinetics and dynamics, even among some age groups. Further, some age groups, even in the same age group, the kinetic parameters and the dynamics, that the way drugs are eliminated, for instance, absorbed, distributed, eliminated, or metabolized may be different in two children of the same age. So when it comes to pediatrics, individualized treatment is very important because of these varying parameters. Within varying body compositions, the water, fat, and protein distribution in the body. Then immaturity too of organs and enzymes, like the liver, the kidney, the conjugating enzymes, and at the early stage. Also, there is high risk of medication non-adherence. As we know, in the pediatric population, they need a caregiver. Somebody else administers the medication, even at home, and the person might forget. The mother might go to work and live with a nanny, and the nanny, we all know how it is. The nanny may forget, may be busy. So that adherence does not really depend on the child, but on the caregiver. And then and this could lead to suboptimal therapy. It could lead to drug resistance in case of like antibiotics. We all know what happens to antibiotics when there is improper adherence. It could lead to resistance. It could lead to treatment failure, even overdosage and the consequences of overdosage. All of these drug therapy problems are more frequent in the pediatrics. And that is why individualized therapy and special care for the pediatric is very important. Also, there could be varying drug effectiveness and safety, even among same age groups, like I mentioned earlier, therefore there's need for dosage adjustment in comorbidity. Yes, some children have comorbidity, and all of this should be looked into, especially, but so many. Now, there's also special need for drug reconstitution. In fact, that one is very important. Now, I had this experience when I first started pediatric pharmacy in my institution. Because initially when I went there, the powdered suspensions were just given to the mother with instruction on how to mix them. But at a stage, I started receiving reports. Sometimes the patient will come back and say, the child did not recover, or the child recovered and shortly came back. So I'll now ask them, how did you mix? How did you reconstitute it? I remember then, they used to tell me, that they boiled water and then put the hot water in the syrup and then let it to cool down before giving. Some will even tell me that they boiled water, and because the water was hot, so they mixed it with cold water before reconstituting. So we're looking at all of the in my facility that nobody gives out any powdered suspension to a patient. It has to be reconstituted properly, and then the caregiver will be instructed on how to administer it, because this is one of the areas that can lead to treatment failure and some other drug therapy problems. And then we also know that there could be erroneous belief. There's erroneous belief that the pediatric is a mini adult. But from what we have seen here, we know it is not true. There's also the challenges of prematurity. Example, jaundice, and immature organs. Immature organs, very important, particularly for preterms. There is an inadequacy of clinical trial data. Now, many of these medications, there is no trial among the pediatrics. So that gap is there. We also realize that pediatrics have 3 times risk of drug toxicity compared to the adults. The pharmacokinetic parameters, the pharmacokinetic and the pharmacodynamics of the individual patient concerned. Then the clinical requirement determines that those exact severity in the dosing, the dosing, also the severity of the
come now, it's supposed to come. Let me
with the peculiar pharmacokinetics and pharmacodynamic behavior in each individual. Like we said, may have altered characteristics in one person and not in the other one. There is a changing body composition, which also affects the drug kinetics and dynamics. And now we'll talk about the oral absorption. That oral absorption is not reliable in the pediatrics due to a number of things. One, increased vomiting. Not like some of these syrup, you just have a measured quantity, probably 60 mils or 100 mils, to be given at a particular dosage. And most often, the child would vomit most of those doses. So at the end of the treatment, you discover what actually was consumed was not up to the required dose to treat that condition. So that's why we say that oral absorption too may not be reliable because of the MSs. Now, there's also higher rates or frequency of diarrhea in the pediatrics, which may affect the therapy. There's also higher risk of malabsorption syndrome in newborn infants. And this could cause autoimmune reaction, which may lead to celiac. Now, the pH is another issue. That the pH greater than 4, the pH in the pediatric is greater than 4 due to the reduced hydrochloric acid production. There is also reduced bile and pancreatic enzyme, hence reduced absorption of fat-soluble drugs. Example, vitamin A is absorbed, 30% is absorbed in newborn and 70% in the adults. There is reduced hydrochloric acid production that leads to increased bioavailability of acid-level drugs, example, penicillin or erythromycin. Also, with pH greater than 4, there is reduction in bioavailability of drugs like phenobarb, phenytoin, due to the stopping of weakly acid drugs. There is better absorption of basic drugs as the pH increases. That's 6 to 8 at birth, while in adults, 2 to 3 pH. At 6 months of age, hydrochloric acid increases and gets to the same level as that of the adults. Then there's decreased blood supply, which leads to reduced absorption. Decreased gut flora also at birth, which could easily lead to diarrhea. There's excess of antibiotics in newborn leads to diarrhea. That's where excess antibiotics is given. You discover that some cases, any little cough, it will be antibiotics, diarrhea, antibiotics. And at the end of this, it leads to more diarrhea because the gut flora is kind of removed. Now, talking also about IM administration in the pediatrics. Like IM is a rat in the newborn, particularly the premature, for phenytoin, digoxin. Because of this, one, there is this lean body mass in their pediatrics. So IM often in the newborn is reserved for vitamin K. You know that some babies that when they're born, vitamin K has to be administered to avoid bleeding. Also in vaccine or where IV is impossible, IM is given. Also dermal drug administration is also given. And this depends on the body surface area. It is very high in premature and newborn due to marked body surface area. There's increased body hydration and drug perfusion in the newborn more than that of the adults. There's also thinner corneum stratum in preterm newborn, and there's marked dermal absorption. In other words, medication drugs are easily absorbed topically in the newborn more than in the adults. Example, hydrocortisone increases adenocortical suppression. That's just the cream that is applied topically, but because it is more absorbed in the newborn than in the adults, so it could lead to this adenocortical suppression. Also, theophylline in premature can increase apnea, while epinephrine can lead to marked high blood pressure. Now, body composition based on age. Well, we can just go through the table there and see that for protein, for water, and for fats, we discovered that in the premature baby, the protein, yes, the protein composition, well, it's about the same in the premature and in the term, but it increases with age. But I guess to 16.5 in the adults, and then at older age, it reduces back to the level of the preterm baby. There is high or marked water composition in the preterm and in the newborn baby more than the adult, and it also increases with age. And then fat, fat deposit is relatively low. It's about 6 in preterm, about 13.4 in the child, and then it increases in the adult. Okay, and then also talking about the composition of administration of water-soluble and fat-soluble medication. We discovered that where it is, there is higher milligram of water-soluble drug, example, gentamicin. Discovered that the dosage of gentamicin given to pediatrics, when it's higher compared to that of adults. Like at the initial, it's 5 milligram, I think it's 5 milligram per kg, the newborn, and then it reduces in the adult. Also, artesunate is given at 3 milligram per kg in children less than 20 kg, but it reduces to 2.4 milligram in children with weight higher than 20 kg. But there's need for higher drug concentration in compounding for kidney disease. Now, plasma protein binding that is seen in the pediatrics. Talking about volume of distribution. There is lean mass in the premature and the newborn infants more than the older children. Okay, we have also seen that blood with increased volume of distribution have reduced dosage, that's reduced milligram per kg, mainly in liver disease. In other words, when calculating dosage for the pediatrics, we have to consider the condition of the liver and the kidney and other internal organs, because they affect the distribution, they affect the metabolism also, and other parameters. And then see the metabolism of some of, like morphine, for instance, in preterm. In preterm, it is longer. It takes 10 to 20 hours, while in full term, it is just 4 to 13 hours. Talking about half-life. And then in infants, it is 5 to 10 hours. Paracetamol, the same thing, undergoes conversion in the uterus. Early infants also go through sulfation, and then later in life, it goes through gluconic diazidation. There's reduced rates of metabolism and clearance in the newborn. There is active biotransformation, example of theophylline, aminophylline, caffeine. To be reduced dose in the newborn. Same thing with renal elimination. Like we have got the renal elimination too. All of the parameters have to be considered. There's a longer duration, for instance, fusemide has a longer elimination rate, pediatric than in the adults. It has like 10 to 20 hours. That of adult. 10 to 20 times, sorry, that of adult. Gentamicin in premature takes 18 hours for elimination to be complete, whereas in the adult it is 2 hours. And there is need to reduce the frequency of dosing. That is why I know that sometimes gentamicin in the pediatric is given at 12 hours interval, sometimes even one, because of the longer period before, longer half-life, longer elimination half-life. Then some of these drugs have marked unbound fraction in the neonates. They include penicillin G, doxycycline, and none of those drugs on the table. Now, talking about dosage, most often in the pediatrics, the dosage is very calculated based on milligram per body weight, but most often for more accurate dosing, the body surface area is considered. Like he's saying here that the milligram per kg is easier, but it is not ideal. That milligram per kg per day or milligram per kg per dose or milligram per kg in divided doses, that can be used. But also sometimes severity of the condition determines the dosage. Example, amoxicillin clavulanic acid, we given 90 milligram per kg per day in the ear, nose, and throat conditions. And then it is given 25 to 50 milligram per day in mild disease. Then the child dose must never be greater than adult dose. No matter how big the child may appear, it should never be greater than adult dosage. That is why sometimes, even when it is the manufacturer recommends certain milligram per kg, but you say it should be lower than, I should not exceed the adult dosage. Because of all those parameters we have considered, then knowing that the pediatric, the vital organs are not matured as that of the adult. Okay, different. The body surface area is most ideal, like I said before, in the pediatric dosage. The calculation is there. We don't have to go through that. There's a Clark rule for pediatric dosage. There is a Young rule also for the child dosage. Now, principles for rational dosing, saying that the pediatric is not a mini adult, in contrast to Clark's and Young's rule. Like Clark's and Young's rule assume that the pediatric is a mini adult, but in reality, that is not so. So it requires individualization of therapy in the pediatrics. And then pediatrics have higher milligram per kg. And then there is drugs. And vice versa for bag soluble drugs. Then the IV is best due to lean body mass in newborn and premature infants. Then parenteral absorption is more than oral absorption due to vomiting, diarrhea. I have already said that. Then weight-based, that milligram per kg, is more practical, but is less ideal. So reduction in dosing for premature is necessary. Premature baby is necessary. And most drugs show first dose schematic and second multi-compartment model. So there is need for therapeutic drug monitoring in the pediatric due to poor medication adherence. And there should be caution with the benzyl containing products. Absence of safety data due to non-inclusion of pediatrics in clinical trial. All of these affect the pediatric doses. Also, post-conceptual gestational age and post-natal age. All of those are important parameters to be considered in the pediatric dosage. Okay, now we mentioned specific pediatric characteristics. They include fever, which is a subjective term. And then pyrexia is the objective term. Hyperpyrexia, where the temperature is 39 or above. There's the intact hypothalamic function. In that case, NSAID or paracetamol would counter the pyrexia. It is hyperthermia of 90 degrees and above. Dysfunctional hypothermic functions. Example, malignant hyperthermia with suxametonium, bromocriptine, and the rest of them. The body temperature less than 35, that is hypothermia. 36 to 37 is normal thermia, and greater than 37.5 is regarded as pyrexia. And then convulsion, say 0 to 3 months. If the child is febrile, then cause could be CNS disorders, like birth asphyxia. For children 3 months to 2 years, it could be febrile convulsion. And then respiratory rate for children is there on the table. It decreases with age. At birth, it is higher and then decreases with age. Then pulse rate too follows about the same pattern. At birth, it is about 160. And then at the age of 6 years, it decreases to 100. And of course, for the adults, it comes down to between 60 and 100. And then some common newborn disorder that mainly due to the abnormal transition from fetal stage to neonatal or newborn stage. They include respiratory disorder, which include neonatal wet syndrome or transient tachypnea of the newborn. Then failure of inadequate adrenaline. Okay, because of its failure of adequate adrenaline and noradrenaline to mop up sodium and fluid from the lungs at birth. Usually, this can lead to cyanosis and fast breathing. There's vaginal delivery also. Okay, saying that vaginal delivery helps to compress the thorax and expel this fluid. I mean, for some babies that are born via other means, ES and the rest, they're likely to have this respiratory syndrome. And it increases in premature babies. Now, very important that dexamethasone is used in such babies to induce the lungs, to induce maturity in the lung, particularly in premature. Sometimes when babies are born premature, you discover they have this respiratory syndrome that, if left unattended, can cause a lot of complications that might be fatal. So he has a sketch there of the adult cerebral circulation. And then he has some diagram there that I guess will answer some of the, will explain some of that during the question. Then another condition there that is common in the newborn is jaundice. I hope I'm still audible. Hello?
Yes.
Am I still audible?
Yes, you are still audible.
Hello? Okay, I can continue.
Yes, you can.
All
continue.
right. Okay, he's talking about brand selection in pediatrics. It's very important when treating pediatrics. That brand selection is very important. That most pediatricians, they prefer brands that are tested and trusted. It's like nobody actually wants to experiment with a newborn baby, considering their fragile nature. So most pediatricians like to use brands that have already been used over the years. The premature and newborn easily have higher mortality rates. So not all IV products not all IV products of same characteristics. The same characteristic constituent are equivalent. You know that we're talking about equipotent and all of that. There could be 2 or more drugs with the same content, but the potency might not really be the same. And then the ones that are already used over the years and trusted are often preferable. So water-soluble products are best in emergencies.
Yes.
Okay. Fluid administration in the pediatrics. For normal saline, they are stated in there for normal saline. I can take note of the dosage, of calculation of dosage in fluid in children to avoid fluid overdose. Fluid overdose can be fatal in the newborn. Let's say for mild dehydration, less than 5% loss of total body weight. Can use ORS for that at 5 to 10 mils per kg. And they're talking about when IV line is needed. And there is no need for calculating the fecal replacement. Now, for severe dehydration, the percentage required for severe hydration and the rest. Talked about iron administration, that total iron dosage required is equivalent to body weight and the actual HB. And then volume of fat cell. Therefore, kids in their teens who are taller than 5 feet. Talking about the people, the crop goals to fit for the calculation. That is saying that 0.85 for female. But talking about calculating creatinine clearance, the pediatric. The category 1 to 12, 13 to 51, 12 to 51, and none of that. But I think I'll just round it up. Now, we are children dosing, any adult dosing. Then that children have rapid change in body composition, and same with changing pharmacokinetics and pharmacodynamics. So that pediatric pharmacy is emphasizing again that it's a specialty of clinical pharmacy. Specialty of clinical pharmacy, where extreme caution is required with dosage of drug. I think I will stop there for tonight. I'm sure he's available to answer the questions. So thank you for your time. Thank you for listening. I may not have done it the way the presenter will, but we thank God for Thank you very much for listening. Please, the questions can be directed to the presenter answer. If he's still unable to answer, please, I would advise that the question be directed to the platform where he will have an opportunity to easily answer. Thank you very much for listening.
Thank you, ma'am.
So I would like for contributions and questions. As you all know, I was standing in for presenter who had technical challenges and could not make the presentation. So I have been able to do that. For more questions, please, you can let us see if you will be available to answer, but otherwise, you could direct the questions to the pediatric platforms. Thank you, everyone, for coming. Dr. Hafsat. Pharmacist Hafsat, please take the necessary questions, please.
Okay. Welcome, ma'am. Are we taking the questions from the platform?
Yes, anyone that has contributions or questions, please go ahead. The one that can be answered here, other ones can be sent to the platform. I don't know. Dr. CNN, are you with us now? Dr. CNN. Oh, I think it's not here. Okay, like he's not here to answer the question. Please, any contributions? Contributions can be made and then the questions will be directed to the pediatric platforms.
Okay, I think Dr. Timipri is raising her hand. Dr. I think you can go ahead with your contribution.
All right. Good evening, everyone.
Good evening.
Yeah, I really want to appreciate you, Dr. Regina James, for this very wonderful presentation. You know, this is what we in the education committee always tell ourselves, that sometimes if you have a presentation and then you are the moderator, we always tell them to please read the slides. Anything can happen. You can end up being the presenter, and that's what has happened tonight. And you did it so well, Dr. Regina James. So well that people that joined later thought that you were the presenter. I just want to congratulate the pediatrics pharmacists of Nigeria specialty group for this wonderful presentation today. And I also want to urge you, although this is the first presentation you have had since the group was actually created, we want to urge you to continue, moving on. We don't want it to end like this. We want you to do more presentations this year. Thank you so much. It was a very wonderful presentation. I had a little experience. I don't know if the host can please mute people that are not talking. That would help us, because the moderator actually is now the presenter, so she did not have the chance to do that. But the host can help, because we have a lot of background noise. Can help us to mute people who are not talking.
Okay.
So, Dr. Regina, are you still there?
Yes, I'm here.
Okay,
Dr.
thank you very
Unmute yourself.
much. Yes, I've done that. Thank you so much. So I wanted to ask, it's a very detailed presentation with a lot of abbreviations. I don't know whether there's a place where they were actually explained, but I wanted to just chip in something I noticed recently in my own institution. You know, like the presenter has said, physicians like to use what they know what they know actually works for them. So you see them writing a particular prescription, a particular brand, and they stick to it, especially among this very sensitive group, the pediatricians, the pediatrics. You know, I was surprised recently when I started seeing artesunates for them to compound. They want to compound artesunates. Then the first time I saw that prescription, although I was on call, it came because if it was ordinary, if it was the regular time, the prescription won't just come to us when we are on call. It will go straight to the pediatric unit, and those ones will now do their checking before they allow it to come for compounding. So I saw a testimony, and I was wondering, when we compound, actually, we compound drugs that are hardly, existing in that particular form, dose. And I know that artesunate suspension actually exists. So what's happening, although she has explained, the prescriptions will like to, the prescribers, they would like to prescribe what they actually know that is actually working for them. But why compound a drug that has, that is, existing in its own suspension form? If it's scarce, because we know that the prescription comes in all the time. Only that day I worked, I saw about 3. Then why can't the pediatric unit, make sure that they stock such drug? So I just want to ask, is it right to compound a drug, just like telling me to come and compound metronidazole suspension? It will be somehow, because I know it actually exists in its form. So what do you think? What do you say about that? So that's my question and contribution. Thank you.
Okay, sorry, Dr. Okay, are you directing that question to Dr. Regina, or you're opening it up to the platform for response?
In fact, yes, I am actually directing it to Dr. Regina and also to you, Dr. Rona Richard, because I know you are the head of pediatric unit in FMC Yanagwa, and I actually witnessed that in my facility. So you can also throw more light if you want to.
Okay, let's allow Dr. Regina to respond. If she has, if she wants to respond to that, then I can contribute. Dr. Regina can respond to that if you wish to. I can contribute to the response.
Okay, thank you.
Hello, I said I want to share my experience that I had in that direction in my institution when I first started in the pediatrics too. Then the ACT was not that, it was just coming in then. But for complicated malaria, quinine then was used for therapy. And then we used to have a brand of liquid quinine, what was called liquid quinine then. So when quinine is prescribed, we would dispense the quinine. And then this quinine was used. But we discovered, because at that time I was actually going to the ward doing unit dose dispensing system. So I saw it that I saw everything, that the liquid quinine was not effective. The liquid quinine was not working. And then we decided, in fact, a particular patient, we decided to compound the tablet quinine that we had. That compounded tablet quinine was administered to a particular patient. And within, in fact, by the next day, the patient, there was remarkable improvement. And that is how we started. The next patient that required quinine, we were asked to compound it. We compounded it. That patient took it and improved. And that was how quinine, even though the liquid quinine was there, but we were compounding quinine tablets. And we discovered that our patients were responding better to the compounded quinine tablets. So I believe it might be the same thing with some other selected products. That is just what I have to say. Though, generally, if the liquid one is there, if the suspension or syrup is there shouldn't be any need to compound. But in some special cases like that, where the syrup has been tested and it is not giving the expected response, I don't see any problem in compounding based on the experience I personally had.
Hello, good evening.
Okay.
Let me add my voice to this discussion.
Okay,
Hello?
Dr. Danjuma. Dr. Danjuma,
Yes.
you can go ahead.
Thank you. Thank you, Dr. Regina, for that wonderful submission and your presentation. When I linked up, I was thinking, was it not Dr. CNN I was initially arranged for the presentation? So it was when Dr. Timipre now explained, I now understand that yes, Dr. CNN was lost along the line. Regarding the question that was posed, one of the angles was what Dr. Regina said. Compounding sometimes of some of these pediatric drugs is better than the finished product that you see over the or in the pharmacies. The reason is because the stability of the product in those liquids you are seeing.
Yes.
The finished product must have been prepared long ago, and you know that from the point of view of manufacturing process, once if a drug is produced today, deterioration sets in. There are a lot of factors that set in making the drug to deteriorate. The storage condition is one. Moving drugs, you never can tell how that drug, that pediatric drug, is being moved from one angle to another all in the name of supply chain. In the chain of supply, the condition with which drugs are supposed to be subjected to might not really meet it. Most of that we are in the era that where drugs are being moved anyhow without even conveying them in within an ambient temperature that is required of those products to be maintained to maintain their integrity. So if you check the integrity of most of these products that we see as finished product, is better the institution or the organization or the hospital compound such kind of medicament so that the active ingredients that is supposed to be delivered will be maintained. At that level, you also know the vehicle of preparations. Which vehicle are you going to? Because if you are going to use your maybe your BP or Martindale to do the compounding, they will give you all the formula that is needed. And if you are going to use, like, say, BP syrup as a vehicle, you also produce that BP syrup within your institution. So you know what you are actually compounding and you are actually giving. For example, what Dr. Regina said is true. Go and check that liquid quinine. You will see that it's about 9 milligrams per ml. But most of the prescriptions come like 120 milligrams. So how 9 milligrams per 5 ml? And the prescription that will come for a child, maybe a child of less than 5 years, or a 2 years or 1 year, will be like 60 milligrams or 90 milligrams. So you have to do the compounding. By the time you do the calculation, you'll be able to obtain, like, say, that same amount in 5 meals or in 10 meals that the child will be able to consume. But if you use that of finished product, you may end up finishing the bottle, a whole content of a bottle, without having the desired quantity that is prescribed. So most of these things, we have to encourage ourselves to go outside, think outside the box, to create this innovation of doing the compounding ourselves, because that is what will give the patient the desired effect. And then the practitioners, the pharmacists and the physicians, the desired satisfaction that they need going forward. I think basically that is more, because I was also involved in this in several occasions in such kind of engagement, and I see that is working. The ones that they buy from outside is not working. The one that we compound in the hospital is the one that will now give the desired result. So those are the few comments I would like to make. Thank you.
Okay, thank you so much for that comment, our desk officer, to Dr. Danjuma. Please, any other comment or question? Anyone with any other comment or question, please come up with it.
Okay, I hope Dr. Okay is satisfied with that. I just wanted to make a little contribution.
Okay, please go ahead.
Okay, so just to add to what some of us have said, now there are reasons for compounding. Sometimes it's to reduce cost for the patient, like we all know. Now, we had a case today that is directly about what Dr. Oke asked. A patient from the special care baby unit, that's the neonatal unit, was required to compound, and she came to the unit. Before she came, she had actually been sent out to look for artesunate suspension and amodiaquine suspension to buy. She went around all the pharmacies in town. She didn't find artesunate suspension. Meanwhile, she had bought amodiaquine suspension. That's for the neonates. So when she got back, we didn't see that prescription. When she got back, she was now sent to the unit to compound artesunate suspension. That was the point when we saw that prescription, and then I had to find out that I found out that she already had amodiaquine. So for that particular case, it was because they felt that the product was not available. That's why they requested for the compounding, because she actually came with the tablet, artesunate tablet for compounding. Then we did it for her. But there are occasions where, for me, I don't think that we must choose one particular area. There are occasions where, like we have the camosunate powder. It's in a powdered form. So if the patient will have to buy a full pack, like most pharmacies would not want to cut one tablet for a patient just because he or she wants to compound. They will want to give the full pack. Instead of giving the full pack of tablets that will not be useful, why not also consider getting what the patient needs at a particular point in time and prepare for that, giving that patient? We also have challenges with compounding, like I've encountered in a few cases. I went to the neonatal unit and I discovered that the compounded drug was not kept in the refrigerator as we would recommend. And that also poses risk in terms of storage conditions that can lead to deterioration of the drug. These are factors that we must consider when opting for compounding or for the already prepared drug. I just felt I should make these contributions. Then let me specifically mention something before I end it. There've also been occasions where like someone contributed on the in the chat box, where the pediatricians request for compounding of folic acid tablets into suspension, whereas we have it available in that liquid formulation. When I interfaced with the prescribers in the neonatal unit, what they said, including the nurses, was that they discovered that the folic acid syrup often makes the neonates to vomit, probably the taste of it. So they would prefer the compounded preparation, and with the use of the compounded folic acid tablet into suspension, the neonates didn't react the way they were reacting to the folic acid syrup. Thank you.
Thank you so much. But those are some of the experiences we need. And I'll still advise you and all of us dealing with pediatrics. Please, it's very important for us to go to the ward and see what is happening to these medications that we are giving out to the patient. If we go there, we will see the response. We will even see, like talking about putting in the refrigerator, If after compounding today, tomorrow morning you are there in the ward, you will see where it is stored, and then you will advise for appropriate storage. You will also be able to identify the response to this medication, whether the patients are actually responding or they're not responding. Like I said, in the case of the liquid quinine, that's because at that time I was going to that pediatric ward on daily basis. So I could actually see the patients and assess them and know that they were not responding to this medication. So please, for those of us dealing with pediatrics, I will advise that getting to the ward regularly is very important, even if it is just to monitor the medications you have given. Watch how the patients are responding, watch how they are stored there in the ward, and many other things. If you take a step and start going, in fact, you will regret why you were not going to the ward all your years of practice. I will encourage every one of us to take a step and go. Please, more questions or other comments, or anyone that has anything to contribute. We are here to learn from one another. So let's share your experiences, please.
So, good evening, all.
Yes, good evening.
This is from FFC in Egua. All right. Sorry, I want to thank the presenter for a wonderful work. You know, it takes the grace of God to present a work with good care and do that very well. So, thank you, ma'am.
Welcome.
The presentation, I saw that part of the pediatrics area, we have a psychiatric area. And I was wondering, because I know most times we see psychiatric as area that refers to most of the time adults. We actually have the cases of psychiatric cases in children, pediatrics, you know, and if we do, is it possible that we also look at the areas, you know, how to prevent the issue of psych? Because most times you look at adults, talk about genetic factors, talk about the issue of you know, use of drugs. But the pediatric cases having issue of psychosis of cases, to me, is a new area. Please, can you throw more light to that area, please? Thank you.
I don't really, you're talking about how to prevent psychosis in the pediatrics.
So I said that in children, the area you mentioned before, you talk about ORG, pediatrics, psychiatric area, and many other areas in the presentation. So I was asking that most times the issue of psychiatric cases in children are new to some of us. I don't know, in our unit, in our department, in our facility, we have a psychiatric unit, but definitely we don't have cases of you know, children, pediatrics in those areas. So I was wondering what would be the cause of psychosis in children in pediatrics. Is it common? How common is that? Thank you.
Okay, well, in my facility, I really have not seen much of that, but I guess the presenter might have a more appropriate answer to that. So you probably drop it on the WhatsApp platform for him. Though personally, I really have not seen so many cases. I've not seen, like in my facility, we have the mental health units, but in that unit, I really have not seen much of pediatric population in that unit. That is personal. It could be there. Like I said, please drop it in the box for more responses.
Okay, another question I have.
Can I contribute on that?
Yes, please do.
Okay, yeah, you know, it's that area of psychiatry in pediatrics. It's actually a very wide sub. It's very wide, and it's not restricted to issues that have to do with psychosis itself. It revolves around mental health care in areas like depression and all of that. We have such cases that are found in children. And the management is usually a combination of pediatricians and psychiatrists. So Yes, so we have such cases, but the management is usually a combination of pediatricians and psychiatrists.
Hello?
Yes, we are hearing you. Please go ahead.
Okay, just like what Dr. Charles just said, while the pediatricians manage the medical cases, more often than not, the mental status degeneration or psychiatric problems are always being referred to psychiatric unit for management. So it is not as if, just like what you have, even in pediatrics, where all medical cases are handled by pediatricians, but surgical cases in pediatrics are always being handled by surgical team or a specialist in surgery. So it should be viewed along that way. It's just like you have pediatrics, which is very large, very wide field. So also is the psychiatric field. It's also very wide. It cuts across. It's a cross-cutting problem. It cuts across all the population, all the categories of people that you can think of, whether pediatrics or geriatrics, whether women of childbearing age or the adolescent age. It cuts across all ages. So it's not just restricted to you don't have to open a separate unit for pediatric psychiatry. But more often than not, they are always being referred to specialized units that handle such cases. That is the only contribution I have to make. Thank you.
All right.
Sorry, I still have a question with regard to that last comment. Actually, if pediatrics consider based on specific dose for them, their dose is individualized, and if you now refer them to mental health units where they may not be able to consider that the dosing for pediatrics, how are they care of the pediatrics cases of psychosis or depression, knowing that the cases of they have more concentration in terms of the dosing and all that. Is it not better to have a kind of specialized psychiatric physician in pediatric unit? Is it not better that way?
All right. Thank you very much.
Maybe we'll go through some of our literatures and then answer some of these queries on the platform. Because I've done my postings in psychiatry, but you hardly see pediatric psychosis or maybe pediatrics that are having mental derangement. The only area that you see mental status derangement coming in when there is an institution of, maybe you have a convulsion case that will make the child behave as if he has psychosis. Then you will know that in that case, they will now refer it to, not to refer in this case, it will be managed as a case of severe malaria, which also brings about some display of symptoms of psychosis. But then we will maybe provide some of these answers to these queries on the general platform for us to also do a learning curve, because all these things, we are all learning in the process. Thank you.
Okay, I think
that's a very good submission. Please let us share it on the platform so that others who are not even here can contribute to answering some of those questions.
Okay.
Like our time is far gone, I will advise that please, other questions should be directed to that WhatsApp platform. And then once again, I want to thank everyone who has participated, who has come out to this maiden outing. And we hope to maintain the presentation on monthly basis. We are sorry for the technical hitches we had at the beginning, which also prevented our presenter from doing the presentation himself. We want to believe God and we'll also do our own part that by our next outing, it will be smoother than today. Thank you very much for being patient with us. Thank you for hanging out with us. May God bless you.
I hope you'll be able to share the document with us.
Yes, the document will be shared.
Yes, to be shared on the platform.
Thank you.
All right. So please, can somebody, unless there's any other comments, can somebody take the closing prayers, please? Dr. Danjuma, you are there. Please, if you are still there, take the closing prayer.
In Jesus' name.
Amen.
Father, we thank you for bringing us to the end of this presentation tonight. Even as we use this as a springboard to spur us to do greater and mighty things in the near future, we want you to take the lead as we progress in this course, the course of serving humanity, to deliver care to our patients, particularly those that cannot fend for themselves, the children. Thank you for answering us. And we pray that you're going to see us through. In Jesus' name I pray. Amen. Good night.
Amen. Good night, all. Thank you once again.
Good night. Good night, everyone. Good night.